Well, hello, Linda D'Onofrio. It's lovely to have you join me for a conversation this morning.
I am so happy to be here. Nice to see you again.
And for those of you who don't know Linda, I'm going to give you a quick rundown of her bio, and then we're going to jump into some great questions around a paper that she put together. And also, just to let you know, she's coming to Australia. So, any of you professionals in these cities, make sure you get out to see her. We'll tell you more at the end. But Linda D'Onofrio completed her degree in communication disorders at the University of Oregon, her medical externship in the Oregon Health Sciences University Medical Center, and her clinical fellowship at the Oregon VA Medical Center. She has worked as an adjunct instructor, teaching graduate courses in orofacial oops, sorry, lost my moment there. Oromyofunctional disorders. She has reviewed manuscripts for the Journal of Clinical Pediatric Dentistry, Folia Phonetica, a Logopedica. I presume that's
I
Italian.
can't pronounce that journal either. It's okay.
And the Journal of Oral Rehabilitation. Her paper, Oral Dysfunction as a Cause of Malocclusion, in the journal Orthodontics and Craniofacial Research, was awarded the most downloaded article for the journal in 2019 and 2020. She's lectured on oral physiology at universities worldwide, including Stanford, Tufts, and the Vienna School for Interdisciplinary Dentistry. Well, welcome, Linda. It's great to have you here, and that paper is exactly what I want to talk to you about today.
Yay.
All right, so I'm going to jump in with a few questions. The first thing is, as a speech pathologist, how did you become so interested in malocclusions? Because you're quite the expert.
I wanted to specialize in craniofacial disorders and cleft palate. And so malocclusion is just part of that larger dysmorphia. But there weren't actually in my area really enough for me to be on the cleft palate team at the local hospital. So I was trying to pick them up as a community provider. And then my very first job while I was doing my fellowship at the VA was with a speech pathologist named Joanne Smith Peter, who happened to be a myofunctional specialist and has published papers on the topic. And so while I'm working at the VA, while I'm trying to specialize in craniofacial disorders, I'm learning about myofunctional disorders. And so the first time I ever saw an open bite on a child, I got very, very excited because at least the hole was here and not in the roof of the mouth. And I thought, oh, so malocclusion is just part of facial dysmorphia and disorders, and it's something I love.
And that's a great way to put that in context, isn't it? It's part of the whole craniofacial disorder piece. And so I love that. And I love the fact that as a speech pathologist, that's big picture what you guys have a very broad overview of what you do in practice. I used to think speech pathologists, they are working with speech, but actually it's so broad, isn't it?
Well, and speech is the symptom that you hear. But I say often in my courses that oral malfunction is the nexus between craniofacial structure, swallowing and feeding, and communication, because it's all happening all in this critical area of our body.
And you guys are the experts in the field. So can you describe for our listeners what an OMD, or an orofacial myofunctional disorder, is, and how early can we see the signs of this dysfunction, these signs you're talking
Uh,
about?
I had the privilege in this paper of defining this disorder only because I kept searching for a good definition, and there really wasn't a cohesive one. You'd find a definition that was maybe a paragraph long, and so I had the opportunity here. But for someone who's non-medical in any way, it's any dysfunction of the face and head. So it could be dysfunction of the jaw, the lips, the tongue, the oral pharynx, or even the nasal cavity to some degree. So it's just dysfunction, and it could be part of a facial disorder, but those two things grow together over time. So
And how young can you start to see the signs?
you can see it on the day a child is born if you know what you're looking for.
Yeah.
So if a child is born with a very recessed jaw, that is something you can see. You can see a high narrow palate on a day a child is born. These are concrete, bony structures that are observable.
Yep. Fantastic. So let's talk through some of the most common causes of OMDs and how they impact on the way the face is growing and functioning?
You can encounter a myofunctional disorder at any time in your life. Okay, if you have a heart attack in your 60s or 70s, that will change how you breathe, how you exercise, how you sit, how you swallow, how you sleep. And so you can see a co-occurring thing at any point in life. But the biggest impact is breathing. So any change in normal nasal breathing can be the beginning of oral dysfunction, which can lead to oral myofunctional disorder, but also swallowing, chewing, the major functions of the face. So breathing is the first and most important thing that we do, and so it's usually the first symptom I'm looking at when a patient presents in front of me. Is like, do we have a history of breathing difficulty? And then I begin looking at other functions.
Do you want to just connect for the people listening how the function affects the growth? Because sometimes I think people don't, oh, how does the way you swallow affect the way something grows? And yeah, just to sort of connect that up a little bit for
Okay, there's a couple of ways. Okay, the easiest analogy is just our legs. Okay, so if we are a normal child and we're running and jumping around, the muscles and bones of our legs are growing together. The bigger the action, the bigger the muscles grow, the denser the bone, the denser the bone can grow. The denser the bone, the more the muscles can take and load, and these systems can grow together. If a child happens to live in a hospital as a child because they're sickly and the legs don't form normally, it's because the muscles are weak, the bones are more porous, and even if that child rehabilitates later on in life, this beginning can change structure and function throughout the rest of their life to some degree. Okay, so that's just a big bony thing that we can see. But the same is true in the face. Okay, so our muscles and bones grow together in the face and they can weaken together in the face. So if you use things normally, they develop normally. I hope that analogy made a little sense.
yeah, I think we sort of forget. I'm very passionate about chewing, as you know, big functional movement for the face and the growth of the jaws. So, yeah, so that's why I just want to make sure we get that.
Well, with you and I both have a passion for older patients too,
Yeah.
because in my world, osteoporosis in the face, in the jaw, leads to tooth loss. And the
Mm,
best exercise for the muscles of the face to maintain the porosity of the bone in the jaw is dense chewing.
yeah.
I mean, you can do exercises too, as you well know, but the natural function of the face would be chewing dense food. And as you get older, if you eat softer and softer foods, then this reversed relationship between the bones and the muscles can occur.
Yeah, it's all connected. Now, what I'm seeing in my practice, and you're probably seeing this as well, this is real awareness around mouth breathing, that it's becoming more prevalent and the awareness is really picking up around it in the children, particularly. Can you talk us through? You talked about it being one of the biggest impacts. Just connect those dots a bit more around how breathing starts to become symptom of craniofacial and OMDs.
I think there's so many reasons somebody can be mouth breathing. I mean, I can be just stuffed up on a specific day, and that day I am mouth breathing. Okay, so it is a presentation. And while in some areas mouth breathing may be becoming more prevalent in children, you could probably look at a population maybe 30 miles away with different flora and different weather systems. They may present a little bit differently. There may be children that have high allergic reactions in some areas that these allergic reactions don't happen in others. So truly the reasons for interruption of good nasal breathing, again, it's its own course, truly. And so the reasons for it, I think, are the most important. But why it can have an impact on the face, and this has been known, this is not something I invented, this has been known literally for hundreds of years. And Weston Price, as he moved through the United States and saw the difference between the English population that was moving and the Native Americans, were the way you breathe. And of course, they're moving into an industrial environment in England. The mouth breathing only got worse for hundreds of years. It changes the growth of the jaw specifically. So if we're closed mouth nasal breathers and the jaws are aligned, sorry about that, they will grow together. But if the jaw is open to accommodate breathing, the angle of the jaw growth will match the angle at rest. And that can have a long-term effect on the whole
Absolutely.
face, not just the jaw, the whole face.
On the whole face and how it functions ongoing. So what does ideal rest posture look like? Because we know that mouth open sitting back is not ideal. So talk to our listeners about what does it look like when it's ideal so that we can start to recognize and work towards that. And how does that have an impact on the facial growth?
I talk to my clients a lot about what you do when you do nothing might be the most important thing that you do. And again, I try to make big body analogies. So and we'll talk about what ideal rest posture is, but think about ideal body posture. You can exercise every single day, but if you are slumped over, your stomach muscles and your butt muscles are going to take on a different form, even with exercise, because of the posture. So an ideal resting posture is with lips together, teeth lightly apart, if that's normal for you. They may be touching, but not touching with pressure. The tongue should be fully from tip to the end, suctioned lightly to the roof of the mouth. But if the roof of your mouth isn't a good suction cup, that is not always easy. And that the face is really quiet at rest. So that when we do something like swallow our saliva, you shouldn't see it at all, because it really only should be the back of the tongue that's kind of moving as saliva gets drawn up, through the cheeks. And so a resting face should really not have a lot of movement as it's breathing, as it's swallowing, and that is ideal. And so that's like what we're looking for when we first meet our clients is how comfortable are you at rest during saliva swallows and then during these larger functions.
I like the way you've described that there in the analogy of the everyday body posture in relating to, you can go to the gym and you can do all the exercises. We can do all these things, but it is actually the thing you're doing thousands of times a day, which is you swallow. When you do and also when you're eating, chew, swallow, breathe, if that's working well, you're getting really good functional movement every time you eat a meal and swallow your liquids and all the things you're doing. But when it's dysfunctional, it means you're kind of getting the opposite. You're getting negative impact.
And what I want parents to truly understand is if a child has to choose between chewing and breathing, they'll choose breathing every single time. Yeah. And so one of the home experiments I have my parents do is to put a clothespin on their nose and eat lunch. And I promise by the 5th, 6th, but definitely by the 10th bite, your swallow has completely changed. You're thrusting everything because you have to choose between breathing and swallowing. And the only way now to get the bolus down to swallow that food is through this tongue thrusting action. So a lot of my parents, just by watching themselves with their nose occluded, eating a meal, can understand everything their child has been experiencing just like that.
That's very cool. And it's great, isn't it, when a parent can understand, that's what they're doing, because they're in the survival response. And we're very clever at making ways around things, aren't we? If the nose is blocked, then we'll use the mouth. And if you can't use the correct swallow, you'll use some other muscles to make it all happen. But it's a lot of effort going
When I can't breathe, I talk.
When you can't breathe, you talk. There you go.
Blah, 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 blah.
There you go. Yeah. It is interesting seeing our patterns, of what we do. And you're more aware than most, I'm sure. Okay. Swallow. This is one of the things I think is so fascinating. The swallow pattern. Can you talk us through what an ideal swallow pattern looks like? Because that is something we do, and then how to recognize that atypical swallow pattern.
Okay. It has to do with what's in the mouth. And this is truly its own course. So everything I'm saying is I can just feel people screaming at me as I'm beginning. An ideal swallow of saliva, we kind of discussed. There's really not a lot of tongue function to it at all, okay? As we move up textures, swallowing thin liquids like a sip of water is not different from a swallow of saliva, except in volume. Okay. But as I move into a thicker texture like yogurt, and then a thicker texture like a sandwich, and then a thicker texture like meat, and then a thicker texture that may be chewy or sticky, the way I will finally swallow that food has some variation, okay? And my age might change. If I drink something while I'm eating, that can change it. You know, you've had food that you're like, I need to get something to drink. I just can't get it down. So swallowing by itself is, again, very complicated. But when I'm meeting somebody, I can learn everything from their saliva swallow. It's just a matter of time. So I do a lot of watching in the waiting room, not just of my patient, but of the family that they've come with. Because as soon as I start talking, everybody's swallow changes just like that. You know, I'm like, everybody starts sitting up straight as soon as I'm in a room. It's very funny. So, but you know, that's why I do like kids to bring their own food to eat naturally in front of me, for parents to share videos of meals at home so I can see, because what you see in the clinic is a child eating in front of a stranger. Okay. And so I often, when I have a parent, I'll go, hey, is this what Billy does at home? And mom goes, I've never seen this before in my life. And I go, well, when we know what Billy is capable of, send me a video of Billy at home eating pizza with his brother. We'll talk again tomorrow. Because if you want to know what true function is, watch a 6-year-old eat a meal.
Yeah, that's right.
With a friend. That's function. Watch a boy eat a meal with a friend, and you'll know everything you need to know about what people can swallow without chewing, and just all the things, all the wonderful things.
That's great.
So an ideal swallow, again, an ideal swallow though, the tongue tip is stable. Okay. No matter what's in our mouth, the tongue tip is stable against the roof of the mouth. Okay. The chewing might be sloppy, the tasting might be sloppy, but when the tongue isn't stable, you'll see things like tongue thrust. So what you want to see during the swallow is a stable tongue. Doesn't have to be strong, doesn't have to be cute, it has to be stable. So to answer, sorry, that was a long walk, Coffee.
No, that's great. That's great. And as you say, it's not something you can, it's a whole piece of work to understand. The level of complexity in swallow is phenomenal. I'm just blown away by the amount of nervous information that's required coming in to coordinate and get that whole system working well. So when it works well, brilliant. But it
And
can
I'm
get
an old waitress,
challenging.
and I love watching people eat. Watching someone eat food they do not like versus watching someone eat a meal that they are truly enjoying, it's not the same thing. So a lot of dentists will say, oh, I watched the patient chew in my office. And I'm like, chewing on a little piece of blue paper is not what chewing looks like. I'm sorry. I'm sorry. Go down, watch rugby team eat. I literally saw a man eat, spit out his tooth, and keep eating one day. It's not what you think it is. You need to watch boys eat, is all I gotta say. I mean, y'all know. I'm sure Australian boys are fun to watch eat as well.
Ah, yes, always learning. Where are my questions here? I'm just
I'm
up.
sorry about that.
Now, this is something I'm really interested in. A dysfunctional swallow pattern, can it have an impact on the way the airway growth occurs and the way it functions at night?
2 questions. Okay. So absolutely, because again, breathing and sleep are breathing and swallowing are intertwined. You cannot separate them, although we try to medically all the time. Okay. So right now you're sitting very comfortably and you're able to swallow. And because your swallow is stable, your nasal breathing is not interrupted. But if I'm laying on my back and I don't have the greatest craniofacial shape, I'm very docolocephalic and my palate's like this, it's a disaster. And if I'm laying on my back and my lips begin to open and my jaw falls backwards, and now I'm no longer at an ideal resting posture, and I go to swallow, I'm going to finish this maladaptive swallow with a bad rest posture. There's no way I'm going to go back to closing my mouth and my tongue's going to go to the roof again. So if I'm able to maintain a good swallow, then I'm able to maintain good rest posture. And again, this is very important but it's more important when you're laying on your back or even laying on your side, so that as the saliva drains down your cheeks and you swallow, that pattern isn't interrupted. When it is interrupted, gravity takes over, and that tongue's just a big piece of meat. It's eventually, if you just keep breathing in long enough, and we're apneic or hypopneic if you're a girl, because we don't always get apneic. But so, eventually you're going to have that. So that's how it kind of disrupts sleep. If this happens for years at a time, or during the critical years of facial growth between 4 and 8 years old and 8 and 12 and all that, well, the easiest way to put this is anything you do for 5 years, I can see it on your face. Anything you do for 10 years, I bet I'll see it on your face for the rest of your life. So if you suck your thumb for 5 years, I'm sure going to know that. But if you sucked your thumb until you were 10, I bet I'll know when you're 40 and 50, because I've ruined a lot of good movies for my husband by yelling out loud. I think Liv Tyler sucked her thumb until she was 12, and she had. And there went Lord of the Rings for me and my husband. So, but chronicity matters. So when you do anything healthy or unhealthy, or a combination of the two, you can see it over time. And if you do it between 4 and 8, when the face is growing, the face may not fully recover.
Yeah. So it's pretty significant to get onto this stuff early. So what do you think are the most important steps we can take to prevent malocclusions and the impacts they're having, like you just said, on the facial growth? So what can we do?
Everyone knows early intervention works. Name anything else in child development, and we know that early intervention matters. Why do we do vision testing at birth if vision wouldn't be important? And of course, a child's going to have different glasses all throughout their life, because the vision's going to change. So it's not like you're going to wait till 9 years old and then give a child their first set of glasses, because they're just going to need another set later. So this idea of early intervention in craniofacial growth through either pediatric dentistry or early orthodontics is somehow controversial, when it, to me, just makes the most sense. I've had doctors say, well, why should I put a set of braces on them? They'll need another set later. I'm like, yeah, like another set of glasses. Prosthetics work the same way. Why give a kid a leg? They're just going to need another one. So this idea of how to prevent it is called early intervention. We know this. Some of these children we can see at birth. Some of these children we can easily see at 3, 4, and 5 when they present in our offices. We certainly see them at 7 and 9. So, we know this. And I do want to tell you a little side story. Me saying that in my paper got me blackballed from a university. For orthodontic university would not have me after I said out loud that early intervention is what we should do, because that's not what they do.
It's kind of crazy. That tide has to change, because really the teeth are just telling you things, aren't they? Ultimately, how the teeth are in relationship to you is a representation of all the other things you're talking about. So you have to, early on, why would you just address the teeth? And like you said, even
Well,
if you
what's
can
really
address
funny is, no, I've never had a set of braces. And even as a speech pathologist, but certainly as a child growing up, no one ever looked in my mouth. I have one of the highest narrow palates I've ever seen without a syndrome attached to it. I have huge maxillary and mandibular tori. I have zero space in my mouth whatsoever. I know a lot of surgeons who wouldn't do tongue tie releases in me because I don't have an intermolar width that is to their criteria. And I'm a speech pathologist with really good co-articulation, and I can do radio voiceover work. But because even though structurally I'm a disaster, I have very good function and compensation and a couple of other things. So there's things we can do, but we shouldn't always have to, because all compensations come with consequences.
Yeah, and I think that you've made a really good point there, and I think that's the thing. Function we have been functioning around these compensations and adaptations for a while now. Unfortunately, we've just got this cascade now of so much compensation and adaptation that it's hard for the system to keep adapting. But it's so true.
Well, and that manifests in facial pain and sleep apnea. That's how you know the compensations have broken down.
Yeah, that's right. The body's ability to keep adapting. But it is very clever, as you said, and you are a shining example of that, Linda. And I love the fact that you're so functional and all those wonderful things. I love this paper that you've put together. We'll put that a link to that in this post as well, because it's a paper that's just really well put together, reads really well, joins all the dots beautifully. And we thank you for all you're doing out there to join those dots around OMDs and what they look like in malocclusion and craniofacial disorders. So thank you. And we're very
thanks.
You come to Australia when are you coming? What date do you arrive?
I will be lecturing 3 days in Brisbane on the 28th, 1st, and 2nd of March. And then I will be in Sydney on the 7th and 8th. And I will be in Melbourne, I think, the 14th and 15th. And Perth, I'm going to get these wrong, on the next Friday and Saturday. And Adelaide, the Friday and Saturday after that. It's 5 cities across the country. And I'm so excited to come. So excited.
Well, we're very thrilled to have you. So if you're in the vicinity of any of these cities, make sure you get along and to see the fabulous Linda D'Onofrio. She is many, many years of experience and not afraid to say uncomfortable things, which I think is fantastic, because we do need to be able to have those conversations cross-disciplinary, because you're seeing things differently. You're seeing things that others aren't. So enjoy your time here, and we're very thrilled to have you come to Australia.
Thank you, Mary. Thanks for having me. This is lovely.